Good evening, everybody. My name is Dr. Gigi Ilbayumi, and I'm the founding director of the Rodham Institute, which is dedicated to improving health equity and the well-being of all of Washington, D.C. citizens. We have been through a difficult time. We as a country, we as a society, we as a city. What I like to say is that we're going through two pandemics, one brand new, which is COVID, and the other one, an old pandemic, which is racism, which has really just been uncovered. It's always been there. It's just, I would say, using a medical term, we've had an acute exacerbation. That's really forced a lot of people who have not been aware of these issues to take long, hard looks at what our society means, what it's about, what we're going to be doing. But for those of us that have cared about these issues and cared about African American and other communities of color for a long time, these issues are not new. And I want to tell you that although it can be downright depressing when you think of everything that we're going through, right? COVID, many people have lost family members or lost or loved ones. It's estimated that 84% of the 581 people that have died in the District of Columbia are African Americans. There's, of course, the worsening racism with, an administration that has made PTSD heightened, the post-traumatic slave disorder. It's really bringing up a lot of trauma that's embedded, I believe, in folks' DNA. The discomfort of having to wear the masks when it's 100 degrees outside, our mobility is being restricted. So whenever I feel down or disheartened or discouraged, I listen to the two guests that we have, because these people are my friends, they're my colleagues, and really the work that they have been doing, not just recently, they're not people that just started this work, but have been doing this work for a lifetime, have really helped to give me inspiration and help me really feel that we are in good shape. It's going to be a long road. It's like a marathon. There's a lot of work to be done, but we have the foundation of making some positive changes, and they have actually helped to institutionalize these changes. Before I get started on that, I just want to tell you about the title, which is for this Rodham Impact Speaker Series. It is Community Resilience, and it's an approach to health equity. We have two wonderful panelists, Dr. Wendy Ellis, who is in our School of Public Health. She's actually the project director and the Building Community Resilience program through the Redstone Global Center for Prevention and Wellness. She's going to obviously talk a little bit more about her work. And then Mr. Calvin Smith Sr., who is the Director of Government and Community Relations at Bridgepoint Hospital here in DC, but also the Ward 8 Health Council Chair. And next slide, please. So we already saw that. So, we did not issue a statement for Black Lives Matter. What we issued was this graphic, because I think it speaks to the interconnectedness of all of the struggles. That really, when we're talking about health equity, we also talk about social justice, economic justice, and legal justice. It is one struggle and many fronts. Next slide, please. Here are three priority areas that we've been working on, and youth education programming and workforce development. It is important that we get kids graduated from high school on career paths. We believe that healthcare career paths, we know that when you have Black physicians and other Black clinicians, the care and the health outcomes of Black people improves. We also believe very strongly that we have to train the current people that are in the healthcare systems, because there's a lot of structural and institutionalized racism which comes out in implicit bias and all kinds of other ways that impacts directly the health of the people that we serve. And finally, through community collaborations. We have 6 anchor institutions. Those are our main institutions that we partner with, but we have over 100 partnerships. Next slide, please. We have a website where there is a specific page for all the DC COVID resources that are being continually updated. Next slide, please. This is our wonderful staff, and let me tell you, they have been so hard at work. Ms. Bass, actually, this is our summer training for our middle and high school students. Christina Williams, who's the Director of Community Engagement, has helped deliver 2,000 hot meals and food produce boxes, as well as 2,000 masks all over the city, actually including homeless shelters as well as correctional facilities, not to mention for children, women, and families. And finally, Ms. Ashanti Carter, who's actually a PhD student in the Graduate School of Education, she is the program manager, and she is responsible for helping to put on these wonderful webinars. And we've had, since COVID, a total of probably almost 3 dozen thus far. So we've been working very hard. Next slide, please. Here are our various handles. That's about all I can say about social media. I hope that you can get on there. There we go. Sorry, I jumped the gun. That's our email. That's our social media. And then here are our wonderful panelists. So I think that's the last slide. So the first person we're going to have speak is Dr. Wendy Ellis. And I got a chance to meet Dr. Ellis, and maybe we can put your slides on, Dr. Ellis. Well, let's see you first. Let's see you first before we put the slides on. I'd like to welcome you and Mr. Smith. I'm excited about the conversation that we're going to have. And, you know, as I said, you have been in the space for a long time. And really, I want to just pitch it to you. I'm going to pitch it to you and throw it to you. And please tell us about you and the work that you're doing.
Yes, absolutely. So it really is an honor to be side by side with you, Gigi. You're one of the earliest supporters of my work when that was just merely something that was a germ of an idea as a graduate student at Milken Institute. And certainly, you know, I want to have a nod also to Calvin Smith, who not only has been a big supporter, but has also been an important partner as we do this work here in Washington, D.C. So I want to do a quick dive that really, I think, helps to give us some framing and understanding of resilience, this word that kind of sticks out there. It does have meaning, it is measurable, and it's really important and timely when we think about, as Gigi framed, this pandemic within a pandemic. So this ongoing pandemic of racism, structural racism to be specific, that really is an outgrowth of white supremacy. And so what can we do measurably and collectively? I think it's important to also think about that this is not just a on the backs, although this entire panel is made up of people of color, that how do we do this where we pull white people off of the margins to really have effective change? And that has really been at the center of my work of making sure that it's both multi-sectoral as well as multiracial, and creating, addressing structural racism, fostering equity so that we can promote health, well-being, and prosperity in our communities. So I'm gonna just give you a quick primer. This is what our network looks like. Yes, DC this is my home. So of course, I'm very much interested in outcomes here, but we also have the opportunity to work across the country. And so it's not just the breadth of the work, but it's also the depth. So Calvin and I will talk in the panel portion of this about the depth of the work that's here in Washington, DC. But I think it's really important for us in this conversation to recognize this is not a conversation that we're having alone in Washington, DC. But this is something that's happening across 10 other states with multi-sector partners. And as you can see from those logos, there are partners that are both at the community level, but also at the systems level. When you start to see county agencies, city level agencies, as well as state level agencies that are really focused on how do we undo structural racism in a very intentional manner. So I want to do a level set first off of why is equity at the center of this work. So our work started in addressing adverse childhood experiences, but understanding that as we went into community, we began to really truly understand that what was driving so much of the trauma that we see, the intergenerational trauma, was this, you know, we call it oftentimes in public health, disparities, but what you're really truly talking about are intentional inequities that drive these structural differences in communities. So when you have a difference and immeasurable and almost reliable differences in outcomes, say in Ward 7 and Ward 8 compared to Wards 1, 2, 3, 4, that is very much in the intentionality by design. And so how do we begin to connect these systems to address these community characteristics, to improve population health, and do it in a very intentional manner, meaning that what gets measured is what gets done. So we focus on those very concrete measures, not just of individual outcomes, but what are our systems doing to either exacerbate inequity or to build prosperity. So many of you may be familiar with this framing that I came up with. Well, I was still a doctoral student, but it resonated. It was a simple graphic to really begin to understand adverse childhood experiences, but to get the feel to think beyond just what's happening to individuals and move us away from just thinking about programming our way out of outcomes, but how do we get to those systemic drivers, which means how are we addressing the policies and the practices that reinforce this cycle of inequity. So when we think about, some of those things that we may see if you're a clinician, if you're a provider, with regard to a victim of emotional or sexual abuse, substance abuse, or incarceration, going beyond just addressing the immediate need to going further upstream to think about what are our systems doing to drive these outcomes, not just about the individual behavior, but the policies and the practices that reliably draw out these outcomes. And so that is getting to the context that the community and the family environment really do play a key role in how an individual bounces back. And so this graphic actually helps to provide us a better framing and an understanding of the word resilience, that when we talk about bouncing back, it's not just bouncing back to what we already recognize are inequitable conditions, but recognizing that these systems, what's in the soil here, have an important and pivotal role in actually creating supports and buffers for individuals, not only to bounce back, but to bounce forward and thrive. And so, as we discussed earlier, we have reframed this pair of ACEs to be much more relevant and specific to what's happened and what we've seen with COVID-19. So yes, we have these adverse community experiences, but again, that soil has not changed. That soil has been laid bare. And many of those inequities that are associated with these community experiences have become acutely obvious to us. And that has given us this opportunity to really begin to socialize this conversation around structural racism as a root cause, but more specifically, white supremacy. So this is how the work has evolved in really the last 4 months, and being able to help people to understand that white supremacy, when we talk about this, we are not talking about people, and I'm less concerned about individuals in robes and tiki torches. I'm talking about the belief in white supremacy, that white people should dominate all other races, which really is structural racism. But structural racism was a way to empower a belief of white supremacy, so that you actually have white supremacy as an outcome. And so this is that vicious cycle, that it's not so much individuals that are organized in an idea of hate, as much as structures and policies have been organized to produce white supremacy as an outcome. And so when you think about it from that perspective, again, we get away from what individual beliefs are and understanding how our policies have been written intentionally to drive white supremacy as an outcome. So I use this as a way to help people understand that if we only focused on many of the outcomes that we see today, we will miss the entire foundation of which white supremacy has been built upon. And so, we can certainly look at criminal justice reform and law enforcement reform in light of recent events, but let's not just swipe the icing off of the cake and trade that off and still have the rest of the cake there. We need to really think about the structural portion of this. And so I use this policy timeline to help people understand the depth to which white supremacy has been baked into our policies. And much like a layer cake, each layer, each era has built upon what came before. And so I won't really go into much detail on this because I do want to leave room for us to have a conversation around this. But I do think it's really important for us to understand by looking at this timeline of how we created these systems and these policies that built upon each other to produce these outcomes that we see today. So there's numerous examples of present-day manifestation of white supremacy, but two in particular that stand out when you look at that timeline are despite the 1954 Supreme Court ruling of Brown versus Education, which overturned Plessy versus Ferguson, a ruling of separate but equal, America's public schools today have the highest levels of segregation in 60 years. This practice of funding public schools based on local property taxes is a form of acceptable white supremacy. So public schools that are based on local property taxes, despite the history of redlining, restricting access to federally backed mortgages for whites only neighborhoods. So again, you have these federal programs and these practices that really did effectively cut off communities of color to access to capital. And it created this vicious cycle that not only is it an access to capital, but it reinforces this idea of being under-resourced as a community writ large. So though the practice of segregation in schools was banned more than 50 years ago, 73% of formerly redlined neighborhoods, and that's including here in Washington, D.C., remain areas with the highest concentration of poverty in most US cities, providing a smaller tax base for neighborhood schools. Similarly, in the latter part of the 20th century, criminal justice policy and community policing practice worked synergistically to create brutal disparities in who had contact with police, increasing the likelihood of criminal prosecution for communities of color. Again, we can easily see this pattern here in Washington, D.C. So this cumulative disadvantage that's been incurred as a result of white supremacy and public policy design is readily measured by almost every indicator of health, social, and economic well-being. So just to give you an idea of what we look like at, when we talk about measurable outcomes, those things that are in those yellow boxes, oftentimes we look at these as individual outcomes and how can we reprogram individuals so that we have, say, a difference in student body outcomes or student performance. Or if we think about how do we create access to capital, well, let's teach people financial literacy without addressing some of the policies, the upstream policies that cut people off from even having access to economic mobility. So we reframe this work to really think about what are those systems, policies that are driving these outcomes, and how can we change the real upstream policies that would actually inform, say, things like student retention, student performance. And then also looking at what are in these blue bubbles, are these contextual. So hope, fear, racism, discrimination, all of these things play a role in community resilience. So again, I want to save time for us to be able to talk, but I really share this with you because I want you to understand that when we're talking about community resilience, we do focus on three main sectors because all of the public health literature helps us to understand what are those systems that are most proximal to influencing the outcomes that we see in communities. That's housing, that's public education, that's criminal justice and law enforcement. And no offense to my dear friend Gigi in healthcare and public health, but it's really important for us to understand that healthcare delivery alone is not going to solve these issues. And health as an outcome is definitely tied to all of these sectors. And so instead of pulling healthcare delivery out or public health administration of public health out as a separate metric, we actually look at the metrics that are associated with the performance of, say, being homeless and the negative health outcomes that might be associated with that, to look at what are each one of these sectors' contribution to health and well-being. So this is looking a little bit more closely at the ecosystem of public education and thinking about, just as I said earlier, the disproportionality and resources that are available depending upon your zip code, depending upon your district, and even how we draw district lines so that we concentrate and reinforce these patterns of disadvantage in our public school districts. I also have highlighted there the school resource officers, which are, straddle public education as well as criminal justice and law enforcement, to really think about how do we create these structures that were perfectly designed for what became the school to prison pipeline in many of our cities. This is a close-up to look at the programs and practices and policies in criminal justice and law enforcement, which clearly and rightfully so after the George Floyd incident have become very much a part of this conversation around how are our systems perfectly designed for the outcomes that we see with regard to mass incarceration. So at our center, everything that I'm showing you here is available free for downloading to help you to further these conversations around equity. But it's really important to be able to begin to think specifically about how various inequities in each one of these systems create these cycles of burden of inequity, whether that's economic disparity and chronic disease, and that connection to the outcomes that we see. So, this is one of the graphics that we produced to help people understand that how these programs that were subsidized and set in place by federal policy have created spatial patterns of segregated housing in communities that can still be measured today, and how that is then connected to our racial wealth gap, which we know is directly connected to health and well-being. Similarly, when you think about that connectedness between education and housing, it's really important to remember that, again, we're very much focused on these place-based inequities that are very much laid bare here in Washington, D.C. When you think about east of the Anacostia, it's not the river that did it. The river became a marker, much like any other city across the country. There's always a physical barrier of sorts, whether it's the other side of the tracks, that's literally the other side of the tracks, or it's the other side of the interstate. These things are physical barriers, but reminders of policies that were written to create the outcomes that we see. So similarly, you can look at criminal justice policy and see how criminal justice and law enforcement are disproportionately applied in communities of color, community policing practice in particular, to create this disproportionate contact rates, which lead to disproportionate incarceration rates. And I think this is really important when we talk about child well-being, because here in Washington, D.C., you have parental incarceration as one of the highest ACEs, adverse childhood experiences, experienced by our children east of the river. And so again, you have to think about, well, why is that? Is that about individuals making bad choices about their life? Or is this again about the disproportionality and the contact rates? So this is a way of getting very local and using these data to tell the story of disproportionality and intentionality of the policies and producing exactly what they were designed to do. And that is this burden of inequity. So across the top there, you can look at this and you can see that as the population of color is highly concentrated, so is the concentration of poverty, as well as then looking at the connection to incarceration and contact rates. You can see that the higher the concentration of poverty, the higher the concentration of communities of color, you also have the higher concentration of DOC, Department of Corrections, intake by ward here. And then that is also associated with unemployment, diabetes, heart disease, and life expectancy. Again, the system is doing exactly what it was designed to do. It's perfectly efficient. It's been perfected over more than 400 years. And so that's why it's so important to be able to take this historical understanding of the policies so that we don't just get distracted by current events and current policies, but begin to really understand the intentionality of policy that has been written for more than 60 plus years. And so that's a lot of the work that I've been doing with our partner here at Calvin, who is with me today. I'm so excited to be able to share this platform with Calvin, because we have been working on what does a better normal look like? How do we address some of these policy issues that have been laid bare by COVID and use this as an opportunity, a strategic opportunity to act and move forward to improve outcomes in our community?
Wow, Dr. Wendy Ellis, that was superb, and it really helps to frame this discussion. And yes, I will never be offended by you saying that physicians aren't all that. We're not. For the people in the audience that may not be familiar with these statistics, the Robert Wood Johnson and many other organizations you can Google it and find all kinds of graphics. Only about 20% of what contributes to a person's life expectancy has to do with coming and visiting me in my office or accessing the healthcare system. So as you said, it is, the quality of education, the water that we drink, the food that we eat, all of that. And I would also say that we should use that same kind of framework when we're discussing the social determinants of education, of employment. You just fill in the blank, because that's really the framework becomes very important, not just from a theoretical standpoint, but if we're going to analyze the problems and then really create solutions that are sustainable, you really do have to look at the structural issues. And I've been using another analogy, which is sometimes, to the outside world or other countries in the world, the United States looks like a beautiful house. But what people don't realize is that it's been infested with termites for a long time. And some people recognize that, but others don't. So it's really the foundation that I think is being impacted. So we heard sort of the contextual framework and historical reasons for this. Mr. Smith, I mean, as the chair of the Ward 8 Health Council. Okay, all right. That's my respect to you, Dr. Ellis, Mr. Smith. But as somebody who's been leading the Ward 8 Health Council, first of all, can you tell us a little bit about that? And then maybe give us some specific examples that relate to Washington, D.C. I know that you're, born Washingtonian, and you went to school, high school here and so forth. But if you could talk about how some of the issues that Dr. Ellis is speaking about are being manifest, but also some of the solutions.
Well, thank you, Dr. El Bayomi. It's a pleasure to be with you and Dr. Ellis this evening. Thank you. I'm in total agreement with what Dr. Ellis's presentation. That is something that is at a very high level. And in my job and working with her is to break it down so people who live within the community can understand and act upon this. The Ward 8 Health Council is an organic group of individuals that are very interested in bringing better health outcomes to the residents of Ward 8. We are made up of colleges, hospitals, doctor practices, strategic groups, other institutions that come together every third Wednesday of the month to talk about how can we come together through partnership and collaboration to make a difference in the lives of the residents of Ward 8. What we have been working on, and I am so glad to have Dr. Ellis and what BCR is doing now, as we try to integrate that into the thinking of the Ward 8 community. But the top three things that we are working on now, one is food security, two is telehealth and behavioral health, and three is education and distance learning. Based on this pandemic that we all are suffering from, those who reside in Ward 8 pretty much are frontline workers, are essential workers, and are most accessible to the challenge of this COVID. And so they are the, as we like to say in accounting terms, last hired, first fired. And so a lot of them are now looking for work, but while you're looking for work, you still have to feed your family. And so what we've had to do is take a look at all of the organizations that are doing work in Ward 8 to make sure we have continuity, to make sure that families are fed, because they can't really hear what Dr. Ellis is saying if their stomachs are growling. And so we want to make sure that they have that opportunity. So we began to partner with DC Greens, Food and Friends, Giant Food, Capital Area Food Bank, DC Central Kitchen, and Martha's Table to be the kind of the beacon of where those who reside and in need in Ward 8 can go get some sustenance. We have a great relationship with them. For those who do not know watching this webinar, Ward 8 has a population of 78,000 with only one full service grocery store, which plays right into what Dr. Ellis is saying about the institutional racism and the structural racism that they face each and every day. And so we have to, through the Ward 8 Health Council, we have become an asset to them in order for them to hopefully get some substance to continue. Also, as we look at the pandemic seeks out those who have challenged health systems. And if you are in Ward 8, depending on your socioeconomic status, the likelihood of you having one or two more chronic issues is very high. And with the prevalence of these chronic issues, they are ripe for attack by this pandemic that seems to be ravaging the country. And so what we are doing is making sure that we can hopefully penetrate these homes and make sure that they have the ability to talk to a doctor. Also, it brings a lot of trauma, and I was sure that Dr. Ellis would say the word trauma. She missed that, but I guess we'll get back to that. That through trauma and behavioral health, there's an increase in drug use, increase in alcohol consumption, and so we need to make sure that behavioral health services are available as well. So we're partnering with the district to make sure that telehealth is available as well as behavioral health, having someone to talk to. And we have 5 members of the Ward 8 Health Council that are behavioral health providers that we are sending out across the ward to make sure that they are available to be of assist to anyone who might need their services. And third is education. As of March the 14th, pretty much all district schools closed down. And so that means all of the K-12 students lost the entire fourth advisory period. And the way it looks now, that they will miss the first half of until the vaccine is probably determined. They will probably won't be able to get back into the classroom until January, February. So distance learning is key, and what is DCPS doing to assist those who have the greatest need? Because families realize once their children came home and they tried to teach them, they finally realized, oh, they're not reading at grade level. What can I do? Am I equipped to help them? And the answer 9 times out of 10 is no. So we are working closely with DCPS and our family success centers. The district has resourced what's called family success centers, where they have broken Ward 8 into 5 distinct neighborhoods and resource organizations to provide wraparound services and hopefully be that shiny house on the hill that the community can go to get behavioral health, get tutoring, and get services that are needed for them to be resilient in order to make it within this new normal. And so we have been working, we're introducing VCR to all of these family success centers, and hopefully we can drill down the principles that Dr. Ellis so eloquently laid out, that they can have that understanding and also deal with their current reality. And so it is an ongoing issue. It is an ongoing challenge. And we're rolling up our sleeves. And with the help of the Rodham Institute and BCR and the other players that populate the Ward 8 Health Council, I think we'll be able to make a difference. It didn't harm us overnight, so it won't be fixed overnight. So we will plug forward. As
Absolutely.
Paul Lawrence Dunbar will keep plugging away.
So
That's right.
So
Well, I would say, oh, please go ahead, Dr. Ellis.
well,
Go
I
ahead,
mean,
Dr.
you know, Calvin said I didn't use the word trauma. I was trying not to use all my words in the introduction there, leave something to discuss. But I do think that, you know, the point about trauma and that really, I think my part of the presentation and talk really reinforces is that it should be no surprise that we see this preponderance of negative outcomes with regard to heart disease, diabetes, and such in communities of color, in areas of concentrated poverty, when you take this longer lens and understand that this has been going on for generations. And so, you know, when you start to see these patterns that are passed on from generations, literally the science shows us that this racial trauma, that this intergenerational trauma literally gets under the skin. And so it is being passed down from generation to generation. The other part of this that you didn't hear me say, and I'm very explicit, and this, Gigi, this goes back to what you were talking about with regard to social determinants of health. I don't use that language. And I'm very, you know, and I had to make a conscious decision to not frame these as social determinants, because what we've done with that wonderful work that David Marmot put out to help us to understand these external factors that impact health is, what did we do in public health and healthcare? We immediately turned our lens back to people, and
Right.
not to really thinking about what are the systems and the policies that are
Right.
driving the context
Right,
of which
right.
these determinants, you know, exist. And so they're not social, and they don't have to be deterministic if we
Right.
make that decision to intentionally change the policies and the practices that are driving these outcomes. So in our work, we don't talk about them as being social determinants. Rather, they are characteristics, community characteristics that are driven by our systems. And instead of using them to determine how well people are performing, those are performance indicators of our systems. And so that's, you know, part of the work that we do with our community partners is like, this is the language and this is the reality of which we're operating in, and giving our community folks the voice and that knowledge and that education so that they can then go back to these systems and say, you're not serving us. Don't expect me to just change my behavior if the systems aren't serving us to begin with.
I really appreciate that correction of the use of that term, because you're right, built into that, it is a blame the victim. It's using almost eugenics type language of you are, determined. But I'll also say that, you know, mainstream sort of medicine, conventional wisdom within medicine has always pushed and battled the idea that what happens to you structurally in your community, you know, racism, they've all, oh, that doesn't have anything to do with your health. And of course, as you've mentioned, it absolutely has everything to do with your health. On the sort of the biological level, we know that the telomeres that are in our DNA actually shorten. That actually has to do with being more susceptible to a variety of illnesses, to dementia, as well as premature death. So I think what is interesting about the conversation is that it is bringing the various elements of understanding, finally integrating them together. Another element that I don't think we necessarily give enough attention to, not we, but in general, societally, is that, you know, people see the work that we're doing. Oh, you know, we want to help African Americans, and oh, there's none of this. Actually, you know, there's study after study after study shows that if you do interventions for Black and Brown communities, guess what? All communities benefit, number one. Number two, the economic, not to mention, of course, the most important, that's the human cost. But the economic cost of having these racist systems is actually quite high, because they're paying double and triple. Of course, there are some people that make money hand over fist, right? As we see in the current pandemics and in this administration. And I agree with you that it should not be one person that's vilified. It is a rotten system that has brought us to this day. But I was taking some notes here because one of the things, again, that I don't think people have realized, yes, of course, we know that over 30% of the deaths from COVID have been in Black and brown communities. But what people forget is, because of the pandemic, because of systems being shut down, did you know that there's been a 30% excess death? So for people who are having strokes, those numbers are not, being calculated into the overall deaths or the overall, prices that are being paid, right? And those are disproportionately Black and brown, paid by Black and brown and other disenfranchised communities. By the way, Native Indigenous peoples have some of the worst rates, higher even than African Americans. I want to go to the chats because there are several questions here for both of you. One is asking Dr. Ellis, do you have any kind of training, training sessions for individuals, communities to change policies in their own communities? And then I'll have one for you, Mr. Smith.
So yeah, so all of our tools and resources, the intentionality behind this was to not make this, be a gatekeeper, create all these great tools and this body of knowledge, and then further inequity by only, someone has to pay to play. So everything that we do, we turn it out and we put it on our website. If you're here in Washington, D.C., and you are, working with, say the Ward 8 Health Council or some other entity here in Washington, D.C., we are more than happy to work with you to, create a community opportunity for training information, building coalition building on this, so that this work does become, ultimately, it can't just be the PhDs and the doctors of the world that are speaking this language and have this ability to articulate what's needed as far as systems change is concerned. And so, and the most, I think the strongest advocates are our community members, because ultimately that's whom our systems are supposed to be serving. And that's who our elected officials are supposed to be serving. So our constituents have to be versed and steeped in this work in order to really drive that systems change. So there, you can go to our website and I will put it in the chat box. If you don't find what you're looking for, I'm hiding in plain sight. So, flag me down, email me, and my team can definitely help you with finding some things. There was something I wanted to say to you though, that you mentioned about the inequities, the burdens of inequities, and why this isn't just about people of color. I think in addition to what you spoke to, the fact that in our first document written as a country, in the Constitution, it was about class, and it was there in plain sight. It was who had the rights to vote, who had the right, the access to power. And it was put there in the very beginning, white male landowners. And so understanding that when you take that through line from this written Constitution to today, who is benefiting from these vicious cycles and these vicious systems? And when you think about that, yes, the blueprint for what was done to African Americans was first written actually by what they did to the Native Americans here, the genocide, the full-scale genocide of Native Americans in this country. They built upon that to have the subjugation and oppression of African Americans. And the only reason why, it was an economic motivation to have a slave class. But it was never, white supremacy was never for all white people. And that is, I think, what has actually created more understanding in this present day around what we're seeing around widening inequity. So when you talk about the deaths of despair and the deaths, the extra burden of death because of COVID, it's not just in communities of color, it's also, there's an economic stratification here, which we were already seeing pre-COVID. So I think that that's something that's really important for us to recognize, is that white supremacy, and that's why I said I'm less concerned about men in robes with tiki torches, as for people to understand that the real issue, the real color of inequity here is green.
That's right. And if you want to read it's a very dense book, and I don't even pretend to have read it, but just the title and just looking at the chapter headings, it's called Ebony and Ivy. And it's specifically about Ivy League schools and the roles that they played to actually train leaders, the white, white male landowners rather, to run. So that's something that I would recommend.
If you're going to have reading recommendations, I would also recommend another dense one, but I think it's really helpful for us to understand that white people don't even understand their own history in this country. Is White Trash. And it really does a great job of helping to understand the class system that was intentionally built in this country. And so that, there's more commonality in how white America, rural, poor white America has been treated historically, and certainly what they are experiencing now to what we've been seeing in our urban population. So more common than disparate.
Well, that's right. But we know the divide and conquer is a very good way to rule. Right?
Yeah, we're not going to fall in that trap anymore.
Yeah. Calvin, one of the things that I've always been impressed, and I actually always quote you on this, is the desire by communities, any community, for self-determination, and the role that those of us, whether in academics or affinity groups or supporters or whatever, want to play. You always talk about, this is not a pulling by the bootstraps. I'm not going to take the words out of your mouth. Can you share the independence and interdependence analogy that you so eloquently make? And I'll stop to try to even state it.
Well, you did a good job. Well, one of the things that we try to stress is that how do we move the community that we serve from total dependence to interdependence to independence? And what are the steps? One of the challenges that residents of Ward 8 and probably any and all urban centers is that we've been overprogrammed. And we've been overprogrammed with programs that do not have any sustainability. And so there's always a one-off or a two-off, and they don't come in and really establish trust and bring with them resources that can make a difference. One of the key things that we talk about at the Ward 8 Health Council is that I don't want you to even come to the meeting if you're not talking about any sustainable efforts. Because coming in, and that's why I do not allow any surveys or anything, because that does not help the people who each day look to the east, look to the west to see where their help is coming from, and they don't see it. So we are very much interested in working with organizations that are coming in and really laying down a blueprint for success. And we are working with the council member and advisory neighborhood commissioners to work with their constituents and say that it can't be 100% BCR or Rodham or Capillary Food Bank. At some point, the effort has to come to kind of start meeting them halfway. And when you start to meet people halfway, then you're starting to take ownership of your situation. Mm-hmm. And when you start taking ownership of your situation, then change can happen. So we're very much interested in the teachings and how the teachings bring the residents forward to understand, to grapple with how they got there. Where I always like to tell folks that we never compare, because when you compare, you're looking for winners and losers. Mm-hmm. What you do is you look at the context of your life, where you started to where you are. We all know the decisions that we made to get us to where we are. Now is an opportunity for us to correct some of those decisions to get on a better footing. And so what BCR is bringing to the table is that contextual understanding of how some decisions have been made for us and not by us, and how we can now start taking ownership of who we are and how we can kind of move forward and take advantage of all the resources that are coming our way.
And I'd like to add, the other part of it is adding accountability. So it's not just accountability for behavior change on individuals, but it's really accountability to the systems that are supposedly serving our communities.
Absolutely. I mean, I can to self-critique the academic medical system, you know, and I've actually, believe it or not, I've actually heard people say this recently that just shocking. Oh, there's a new hospital that's going to be opening up. This is a great opportunity to have our research, to have our learners and so forth. And I said, time out. This is not for you. And so the philosophy that we have at Rodham is that we, of course, we have some expertise in let's say health, some aspects, but we are here to serve at the pleasure of the community. It's the community that is the driver. They decide what their priorities are, and that we are there to support, not to impose. And if we're asked to leave tomorrow, that we would have hopefully left enough so that there is a foundation, right? And that's why it's so important to partner with these anchor institutions that actually can help build up their capacity. Because if we disappeared tomorrow, those churches and community centers, et cetera, are there. One of the questions that came through for you, Mr. Smith, was about digital internet access. And I actually can begin to answer that. I would love to hear your response to that. As you both are aware, I was appointed to the Mayor's DC Reopen Task Force. And on one of the committee subcommittees, we actually made the #1 recommendation that we made was to ask the mayor to have free internet for the whole city. We at the Rodham Institute are extremely concerned that the digital divide in both telehealth and teleeducation is only widening. Right now, the high school graduation rate in Ward 8 is 42%, and we know that that tightly correlates with everything in the future of a young person. But it actually, if I as a physician did nothing else but got kids to graduate from high school, I would add 10 years of life to their life. Now, mind you, the gap across the city is almost 27 years. So people that live in Georgetown, their average life expectancy is 94. In Anacostia, it's about 66 and a half. So, you know, this, and then, yes, you can have internet. Okay, you may be deciding between food and internet if you've got computers. You may not have a smartphone, you may not have a computer, and then not everybody knows how to use a computer, right? I mean, we are here where in the District of Columbia, 1 in 3 people are functionally illiterate. #1. #2, that says nothing about health literacy, and it says nothing about digital literacy. So, Calvin, what is happening on a citywide or mayoral level, leadership level to address this?
Well, thank you for that. Conversations are being had, hopefully, to make free Wi-Fi available in the entire District of Columbia. That they also understand that, especially with the closing of schools and the inability for K through 12 students to get in, not only for the social aspect, but for also the educational aspect, and being on the wrong side of the digital divide, that free Wi-Fi may be necessary. They have it on in all district buildings. And so just extending it out to the city, we are trying to talk to them about how it would be beneficial for all if that were to occur. So we need to make sure that I get the backing of BCR and Rodham when I go to my next meeting to say, like, everybody wants this. And I saw the question in the Q&A, and we definitely want to make sure that we pull as many people with us into the room to let folks know that free Wi-Fi in the District of Columbia would not be a bad thing.
Yes, and of course the training, as I say, for telemedicine. Actually, before all this started, the emergency department, and you know this, Calvin, with Dr. Neil Sicca and Dr. Reverend Curry of the Pennsylvania Avenue Baptist Church, collectively we trained 25 congregants so that they would be the ones that would accompany patients on telehealth visits, not to the clinic, but rather in the church. They learned how to put the stethoscope, to listen to the lungs and the heart and get blood pressures, which would increase the community's capacity to provide services You would then be able to avoid all the transportation issues. You would have somebody that could even be an advocate with the individual. Even there'd be built-in follow-up for these people, but there's a lot that needs to be done. I'll tell you one hopeful thing in terms of tutoring, because I'm very concerned that the kids have really run behind. I've been having discussions with the National Academy of Sciences. I did not know that they used to have a tutorial program for homeless kids. So we're trying to see if we can get some kind of infrastructure so that anybody that needs tutoring in whatever field can get that. We also want to call on the various Greek, the African-American Greek organizations and other volunteers, but we would really have to set up the infrastructure to make sure that the help is meaningful, right, to kids.
Well, what I like to do is one of the family success centers that we're working with is called Smart from the Start. And they have a tremendous curriculum that if anyone is interested, they can send me an email, and I can make sure I can share that information with them about how they are going about distance learning for for their family success center in Washington Highlands. I think it's a great program, and I think it's something that can be replicated. One of the successes of the Pennsylvania Avenue Baptist Church and Reverend Curry is that he has developed such a huge amount of trust within the community that people flock to him because they trust him. And so what we need is the same level of trust in our religious institutions in Ward 8, that people feel comfortable enough to take advantage of the resources. If we are to put telehealth in those institutions, it'll be a good thing.
Well, and then, Dr. Reverend Curry, his vision is really to have his church serve as an anchor institution itself, so that not only are you going there to worship, but you're going there to get your medical care, clinics, eventually that's his goal. They actually have a day program. They've got a health ministry that's quite robust. He eventually, there are no movie theaters, in many places, restaurants. The things that on the Northwest side, where you're basically tripping over yourself at all the Starbucks and Trader Joe's, and especially in Ward 8. And then the sad thing is, I used to get my hair done over in Brookland, and the bridge was a rickety old bridge, and every time I was afraid that I was going to, have my tire go flat. And then all of a sudden, the bridge got fixed. I'm like, uh-oh. And then all of a sudden, you see, I don't know if it was Whole Foods or Trader Joe's, and then you see different people in the neighborhood. And so it is sad to me that for a lot of poor people, poor Black and brown communities, that when they see change, it means that they're going to be displaced. Right. Yeah. So we only have a couple of minutes left. So closing remarks, please, Dr. Ellis.
Yeah. So I really wanted to give a moment to address Dr. Tilly Williams' question with regard to having a much, making sure that we're not just speaking to the choir, right? That I'm not just giving this talk to communities of color. And I want to, just really be clear that my work has intentionally been made such that it is a multiracial group. It is a multiracial movement. This system of inequity that has been built, that we are, suffering upon, was not built by Black people, was not built by people of color. Hence, we cannot be expected to dismantle it on our own. So I have been very intentional, even pre-COVID, of having these equity conversations. And that's really what was the basis of the Fostering Equity tool that we just released earlier this year, is like, how do you begin to hold space for these very difficult conversations to really begin to unpack the intentionality of 400, 500 years of policy and practice that has created the system of which we have. And so that is also now, in time of COVID, morphed into this truth and reconciliation process, so that we can begin to have, white people coming in from the margins and really rolling up their sleeves and understanding that if we are truly to dismantle this isn't just about being anti-racist. This is about truly rebuilding a system. And so being anti-racist is perhaps the first step, but how do you become much more active? So my work is really around educating people to be specific around the policy targets that we have to really look at. So I appreciate the question, Dr. Williams. I just wanted to make sure that everyone understood that I am not in someone's pulpit, you know, just talking to us, that this really does, we have to be intentional about having a multiracial effort in this.
Absolutely.
And the reality is that this system is anti-woman, it's anti-family, it's anti-disabled, it's anti-elderly, and actually at the end of the day, the people who perpetuate it, as soon as they're out of power, they are also dispensable. I mean, that's the irony. Mr. Calvin Smith, any closing remarks?
I would like to welcome any and all people who are on this webinar to join us at the Ward 8 Health Council.
Yes.
It is a very interactive conversation. And there is an opportunity, if you are interested in making a difference, there's always room for your input. We have a big tent. We look forward to hosting you, having you, listening to you, and incorporating any thoughts and ideas that you might have that can make a positive impact on the residents of Ward 8 in the District of Columbia. I also want to thank Dr. Tilly Williams, who corrected me that Smart from the Start is not in Washington Highlands. A Wider Circle is. Thank you for that. And if you call me or come to the Ward 8, you'll get a chance to meet everyone.
Great. And to your point, Dr. Ellis, one of the groups of people that have made the 2,000 masks for distribution all over the city from sheets, they're beautiful masks, are our friends at a church here in Bethesda. Ms. Jeannie has just done a tremendous role, and coalition building across all sort of groups becomes very, very important. So I'd like to thank both of you for this robust discussion. We've had one webinar which was called, actually Ms. Ashanti Carter helped to create, called Racism Unpacking Whiteness in the Time of COVID. And I can tell you that we need to have more of these conversations. So I hope that we can invite you both back, and please stay happy, healthy, and keep up all the wonderful work. You inspire all of us. Thank you.
Thank you very much.
Thank you.
Bye-bye, everybody.
Bye-bye.
Bye.